Hello and good evening to everyone. My name is Zsolt Molnar, and this is the fourth edition of the Sip of Science series. And this time we have again two very highly distinguished guests. And let me share my screen with you, because that will just help you to go through what will be the main topics of today. So tonight, or today, we have Professor John Ince with us and Willem Pieter Brouwer, and they published two very important articles in this field of cytokine removal and the cytokine story, especially on short and long-term outcomes. So the main highlights of today's program will be discussions on these outcomes after CytoSorb therapy, whether there is a survival benefit, which has not been proven yet, but let's see what the experts think about it. Now, I would also like to provoke our guests on the mortality as a primary outcome, whether it is a good outcome in septic shock and is it a feasible one, or if not, and then are there better alternatives? And finally, how to move on, how to design further trials to increase our knowledge in this field of the story. So now, may I ask you, John and Willem Pieter, to say a few words about yourself to the audience. I know that, John, you are a physician, so how did you get involved with intensive care? In a few sentences, please. Switch on your mic, John, please.
No, I am not a physician.
Physiology, sorry.
Yes, I know it's difficult, but yes, I'm a physiologist. I have a background in electrical and electronic engineering, and I've done for 15 years research in immunology. So combining immunology and engineering brought me to intensive care medicine. I was for a long time a professor of cell physiology, and together with a professor of experimental anesthesiology. A year ago, I moved my whole department from the Academic Medical Center in Amsterdam to where we are now, which is in Rotterdam, Erasmus Medical Center. And here I have the honor of heading the Department of Translational Intensive Care, which is a experimental department associated with the Department of Intensive Care Medicine here in the Erasmus Medical Center. And I was honored to interact with Willem Pieter Brouwer and Szeged which has led us to CytoSorb, about which we will talk today. So thank you very much for having me on board.
It's a pleasure to have you, John, of course. And Willem Pieter, you are not an intensivist either, so please let the audience know that how did you get involved with this story?
Yeah, so I'm a resident in gastroenterology and hepatology. And I've obtained my PhD in the treatment of chronic hepatitis B, so that's something completely different. And I picked up some statistical skills, and I was doing my training for gastro and hepatology, and I was at the ICU department of the Maastad Hospital, where CytoSorb was frequently used, and I saw opportunity there to just gather the data really and analyze it, and that's how I got involved. And I really have a specific interest in intensive care medicine, so that's how I arrived here, I think.
Yeah, and it's funny because I mean I've known John for, I don't know, several decades now, and I'm also working now in a translational medicine department, which is so, and I have also treated intensive care like applied physiology. So now we are all together, and while John is discussing the technical issues with his assistant, I will ask you, Willem Pieter, to share your screen and give us a short intro on those two interesting publications, about which we are going to have a panel discussion in the next 20 or so minutes.
Okay, so I thanks for the opportunity to speak to you today, and I just want to shortly touch upon the results of our 2 studies. So this really is a summary and for our study. So okay, can you see my screen or? Oh, yeah, it works. Okay, so yeah, so we had 2 publications, one in critical care, one in blood purification. That was the second one, and the first one was in 2019, which is called Hemoadsorption with CytoSorb shows a decrease observed versus expected 28-day all-cause mortality in ICU patients. Here we retrospectively studied patients who were treated with cytosorbent for septic shock. And we did it with a propensity score weighting method. And we looked at patients who were treated with CytoSorb, and we compared them to patients who were treated with CRRT only for septic shock. And there were 67 patients in the CytoSorb arm and 49 patients in the CRRT arm. And because these 2 groups were very different in terms of baseline characteristics, we used the propensity score weighting method. And I will not go into much detail about that. But if you look at the baseline differences between the 2 groups, you are very small after correction. And we actually mimicked a dummy randomized controlled trial. So here in this figure, you see that the green dots represent the differences between the groups, and you can see that's really small. And first of all, we looked at whether there was a difference observed in the observed survival or mortality versus the predicted on basis of the SOFA scores. For both the groups, so CytoSorb and CRRT, and within the groups, so we saw that the CytoSorb patients had SOFA scores at baseline of treatment of 14. That's exceptionally ill patients, and the prediction of mortality was actually 75%. But in reality, we saw that these patients had mortality percentage of almost 48%. So there's a dramatic drop suggesting an effect of CytoSorb here. And we also saw this for CRRT treated patients. They had a SOFA score of 13, which represents almost 68% mortality predicted. But it was 51% in this cohort of patients. And then if you compare these 2 groups head to head by using the propensity score weighting, then you see that the mortality in the CytoSorb group was 53% versus 72% in the CRRT group. So this is really a dramatic difference, I think, with the survival benefit here for the CytoSorb treated group, at least at the 28-day mark. But now we wanted to know if it's also lasting longer, if these patients indeed have improved survival and beyond 28 days. So this is our second study. And here we looked at the remainder of patients from the first study. So just to recap, 67 patients in the CytoSorb arm versus 49 in CRRT arm with high baseline SOFA scores. And now we're looking at 59 patients who were followed beyond the 28 days for a median of almost a year. Here we saw that if you just look at these groups without any additional weighting, then the CytoSorb treated patients and the CRRT treated patients had a similar mortality rate here, or survival probability, if you like. And we saw that for those who survived beyond 28 days, the CytoSorb survival was 80% and the CRRT was 87%. So, and there were no differences here, but again, these groups were not comparable. So we applied again the propensity score weighting. And here you see that the CytoSorb treated patients had a survival benefit over CRRT treated patients. And I just wanted to look at the 1 year mark, because at the end there's still less and less patients involved in this analysis. At the 1,000-day mark, there was only one patient left in the CytoSorb treated group. But here you see that there's a survival probability of almost 40% versus 26% in the CRT group, and this was significantly different. So that was over time, and now we wanted to see when we should use CytoSorb, and for that we looked at factors associated with mortality in the CytoSorb group only, and looked at the factors associated with that, and we saw that the presence of the comorbidity with increasing age, lactate levels, and the presence of abdominal sepsis, which was a protective factor, were associated with long-term outcome, and this model had actually a very good predictive could do the prediction very well, with a C-statistic of 0.8 for both the short-term and long-term outcome. And we just took one of these factors out of this model to look at the predictive probability here. We looked at lactate levels. We saw that if you have a lactate level of above 6, the chances of surviving were very low, actually, with a positive predictive value of 80% and a specificity of almost 80%. While when you had a lactate below 6, your chances of surviving with CytoSorb treatment were actually pretty good. So to conclude these two studies, survival achieved with CRT and CytoSorb in patient septic shock is durable beyond 28 days, and maybe improved for CytoSorb therapy when compared to CRT, but that's in a weighted analysis. And the presence of a comorbidity, especially with increasing age, higher lactate levels, and sepsis other than abdominal origin, were all independently associated with long-term mortality. And lactate levels above 6 were strongly associated with mortality with a positive predictive value of 80%. So this might mean that CytoSorb should not be used as a last resort treatment strategy, but that's open for discussion later on. So this is my presentation.
Well, thank you very much. Going back to the main core of today's topic, my first question goes to both of you. That what is your explanation of this long-term possibility of survival benefit? I mean, how could you explain it from the physiological perspective that just one single treatment, there is no difference for a long time, and then there is a difference? If you see what I mean, it is hard to explain. What is your hypothesis or explanation for that?
Well, actually, I wanted to show that that if you make these people better by using CytoSorb as adjunctive therapy, what happens in the long term might not be really the CytoSorb effect, but so that's not really a long-lasting effect, but it's more telling you something about how sick these patients were in terms of comorbidities, and kidney function, heart failure, stuff like that. And I think that might be an explanation for these findings. If these patients were sicker in terms of developing heart failure or kidney disease, they probably died sooner than 1 year. So I think that's something, but really the data doesn't show it, but I have a follow-up of at least a year. So how sick these patients were, if you get what I mean.
Yeah, John? Switch on your mic, please.
Yeah, personally, the way I look at the whole treatment is that under the assumption that what you're doing is you're making out of a rainstorm a drizzle, and that you're reducing the total cytokine load, if that's what's really happening, then I think the damage to the organs will be exacerbated. And I think that you probably will leave ICU with better kit than if all of these, if you have more organ injury. So I think that would maybe leave you fitter than normal. So I think the challenge would be really to measure very specifically organ function in these patients, and to see how that progresses over the year.
Yeah, I mean, I just have one comment to this, that buying time is possibly the key issue, because we have just prepared a manuscript on hemodynamic stabilization. And in our pilot study, we have also shown that it shortens the need for vasopressor support. And just keeping patients less time in a shock state, in the dire straits, may have a profound effect on long-term survival, although, of course, your data is a retrospective data, so we all know the limitations. But I also know that both of you very much in support of this kind of retrospective propensity matched analysis, and both of you have major criticism when we talk about prospective randomized controlled studies and mortality. So can we have a short comment on the failure rate of the currently available prospective randomized controlled trials with mortality and the endpoint in septic shock, and neither of them could show survival benefit? Of course, it goes first to John.
Well, if I could just make a very short statement about that. Maybe it's good for an aspirin trial in cardiology, but there has not been not one single randomized controlled trial in intensive care patients outside maybe low tidal volume, which has shown a benefit for anything. All of them have either shown as worse or no effect. So the randomized controlled trial has failed utterly for intensive care patients. And I think the statistical approach which Dr. Brouwer introduced into this is really the way forward, because it's a pragmatic approach. It takes into account the enormous heterogeneity, not only in patients, but also in physiological variables and treatment strategies. And I think that this approach is going to really show benefit of certain types of treatment strategies above others.
Well, thanks, John. But how can we tackle, or not tackle, but reply to the criticism when they ask us about this propensity matching, especially these SITPW matching? So this goes to you, Pieter. How can we answer those criticisms when they criticize your papers regarding the statistical method?
Yeah. So I think, yeah, it's true that it's retrospective. You should always look at that you take two cohorts of patients who had a fairly even treatment, because if it's really different, then you can correct what you want, but then it's not really going to tell you anything or going to work. That's one thing. And I think we did a good job at that. So they were really good and good comparable in terms of treatment. For the propensity scoring, yeah, it's mimicking a randomized controlled trial. So you actually say that you make these patients as sick as each other, right? So that's really something that's done in multiple epidemiology studies. It's used in papers such as JAMA. It's really a method that's quite well known, but not for intensive care medicine. So yeah, it's difficult to say you just have to believe it, but I mean, yeah, it's a good method to come to certain conclusions, but you still have to be not too harsh on your conclusions. So that's why I say it might help. Yeah.
Before we move on to another topic, just quickly 2 questions from the chat and the question and answers. One question from Emanuela Keller was that how many days were patients treated with CytoSorb? I cannot recall. Do you remember?
It's a mean of 2 days.
2 days, yeah. And whether inflammatory markers you measured, because it is not mentioned in the paper.
No, we don't have those data. No, it was a retrospective, and it was not designed to do a study, but it was already treating patients. Yeah.
Yes. So my next question is that if mortality, although we know it is an important issue, but if not mortality is the primary endpoint, the efficacy of hemoadsorption, cytokine removal, what would be your suggestion to implement as the best to measure whether this treatment is effective or makes anything better for the patients? So what would be your suggestion for an endpoint? Both of them.
So if you have a hypothesis, then you go back to the pathophysiology of a disease, and you have to first be sure that there's a cytokine storm, for instance. And if you think you want to treat it, then you need to have knowledge of the pathophysiology. So I think that's really important here, for these types of treatment. So that's really something I would say. Yeah. John,
sorry.
Yeah. No, John, go ahead.
Yeah, so I think there are a couple of elephants in the room, and one of them is that vasopressor score, lactate, heart rate, blood pressure is not going to give you the needed information regarding endpoints, and mortality certainly not. So I think what our working hypothesis at the moment is a direct impact of cytokines on the circulation. And that is, of course, the endothelial cells. And the endothelial cells are part of the microcirculation. And we all know that a bad microcirculation, as many studies have shown, is the most sensitive and specific indication of adverse outcome, certainly in septic patients. So there are a number of trials now running looking at using microcirculatory alterations as an indication for giving a CytoSorb treatment or stopping a CytoSorb treatment, and very interesting results are coming from those insights. So I definitely think if that is not the possibility, it certainly has to be something about reducing a number of SOFA score points as an endpoint, but definitely not mortality, which is a very bad endpoint, as all of the randomized controlled trials really have shown until today.
Yeah, I mean, I can entirely agree with you, and that we closely linked to our current discussion is a question on from an anonymous attendee that could we comment on the advantages of adsorbers versus steroids, and how important is the capability of the adsorber to reduce vasopressor needs? So let me just quickly answer that yes, we have shown in our pilot study and almost every observational study reported on a major reduction in vasopressor need. However, I'm not aware of comparing CytoSorb treatment to steroids in a prospective randomized manner. And I think they can be complementary, because steroids, they attack the whole immune system. CytoSorb attack just a certain element of the immune response. So they can be complementary and should be used. So whenever you give vasopressors, you give steroids and the patient is not responding, then possibly this is your only chance to, instead of waiting, then acting in a proactive manner and start and trying to remove circulating cytokines and reducing cytokine storm. Now, John, you mentioned lactate levels as they are not appropriate endpoints. However, you put a lot of emphasis in your paper on lactate above and below 6. And the main questions in this adjuvant therapy business, put it this way, or story rather, that which patient would benefit the most? How can we define those patients who would benefit from adjunctive therapies? Because adjunctive therapies, let it be hemoadsorption or immunomodulation by other means, pharmacological means, it is not proven. And it is very difficult at the bedside to pinpoint those patients in whom you are just wasting your money and resources and those who may benefit. So, and I must say, I'm a bit skeptical about this cutting at 6 of lactates, although your message is clear and the Kaplan-Meier curve is clear. But how do you interpret this at the bedside?
Oh, yeah. Oh, John.
If I could just make a general comment about this, it all has to do with statistics. If you have a lactate of above 6, you have an 80% chance, but you still have a 20% chance of survival.
Yeah.
So if you are a rich person, I would say bring on the CytoSorb.
Yeah.
I think the really important story about this, about the 6 millimolars per liter, is that it really shows what you would expect, that the sicker that you are, and the bigger chance that you have you're dying. It's as simple as that. But I think what is very different from CytoSorb type of therapy conceptually than giving, for example, prednisone or something, is that this is a therapy which is continuously functioning over the time that it's there. Whereas the timing of giving a steroid is very, very uncertain and will have a certain pharmacodynamic which is also uncertain. So I think the advantage of this is that over a lengthy period of time, you can actually influence the particular levels of cytokines. I don't know, Willem, Pieter, maybe you've got to comment on that.
Well, yeah, I totally agree. And as for the cutting, so the lactate levels, I think I just wanted to show that there should be, or there is a sweet spot. So there's something that below a certain level you wouldn't probably do this treatment, and above maybe you are a little bit late. So I just wanted to say that it's not really a last resort treatment, but we have to arrive there first. And what John says is with the 20% chance still of surviving, I think that's a really important point. Yeah, that's really important, I think.
Yeah, so we have a case study which hopefully is about to be accepted, in which we looked at the microcirculation, and that was a patient who survived and who had a SOFA score of 14 and a lactate of 12. And putting in the CytoSorb improved the microcirculation, and after 12 hours started to reduce the lactate, etc. So I think this tells us really about how to consider risk and statistics, and everything is a chance, and the sicker you are, the bigger chance, unfortunately, you have of dying. But it doesn't mean that you're not savable. That's a completely different story.
Yeah. And I don't know if you read the recently published paper in the Lancet Respiratory Medicine, which reported on a completely different survival. This takes us back to the survival story. That what you reported, and when you read the paper, what was your impression? Just for those who possibly did not come across the paper, there was a prospective randomized study on 30 odd patients, a very small sample size, 17 per group patient population, treated with COVID-19 and on ECMO with CytoSorb or without CytoSorb, and the survival was extremely low in the control group as compared to currently published COVID-19 data, and less than 20%. And in the CytoSorb group, it was extremely high, above 70%. And that was surprising on both ends. And I mean, I'm really interested in your very positive attitude and results that CytoSorb may even improve survival. What do you think of this?
Well, they actually stipulate that there's a cytokine storm, right?
Yeah.
But is that really proven? I'm not really sure. That's something that's almost always said about COVID-19. But if you look at the baseline characteristics in the table, you see that there's a lactate of less than 2 for the total group. So there's not really a shock there with the noradrenaline levels of 0.15, SOFA scores of 9. Well, that's completely different from what we have in our population. We have SOFA scores of 14, lactate levels at the start of therapy of 7 actually. So that's a mean level. It's really high. And our noradrenaline levels are 1.0. So that's really totally different. And then, yeah, the question is there really a systemic cytokine storm which you have to treat in this manner or not? I'm not really sure. In our patients, at least I can say something about that. They really were in total refractory shock, so that these patients were actually very in need of dampening this storm. But if I look at the characteristics of these patients in the Lancet paper, I don't see that. That's one thing, and the other thing is that I do believe that the site of infection and the pathophysiology is really important here. So what is really happening with COVID-19? There's a lot of thrombosis at the microcirculation level, which hampers the ventilation of alveoli, and that's one part of the pathophysiology point. So I'm not really sure what's if we're not comparing apples to oranges here, and I do think that we need to know more about the pathophysiology. Actually.
Yeah, so I think you're comparing apples to peanuts, basically, with this study. I think this is a classic example of why randomized controlled trials that are being published in these high impact journals, they're always in the Lancet and the New England Journal of Medicine. So I'm a physiologist, I can say all of these terrible things, but this was a really poor study. So if you want to read about what's going on with COVID, read our microcirculation paper in critical care medicine, and you will see actually that the real focus of the disease are the lungs. COVID-19 is not sepsis. And this particular paper, it's unbelievable that this got accepted. How can you randomize controlled trial? You do with large numbers of patients. These patients, there were 34 patients. In their secondary endpoints, they wrote that fluid therapy was an important second. They say nothing about it, whereas they're giving 3 liters more in their CytoSorb group than in the other group. And we know that fluids, additional fluids, have got an adverse effect on outcome. Nothing is mentioned about that in this whole paper. And also the control group, the IL-6 levels are going equally rapid as in the CytoSorb group. Again, nothing is said of this. This wasn't comparing 2 things with each other. They just had, their control group should have had high levels of IL-6 or different levels of IL-6. They were also giving prednisone and a whole lot of other stuff which was affecting their patient groups. And they have taken out one example of the CytoSorb absorption, and then they conclude at the hand of just 34 patients a cytokine, a mortality. And it says, although our trial was not designed to assess mortality, well, it didn't, but yet they make a big point out of mortality. So I found this, and I think another important sentence is, the data collected during this trial does not allow further analysis and understanding of the reasons and pathophysiological basis explaining the increased mortality. Well, sir, I think that is the nail on the coffin of this paper, because if you don't understand that, you're doing witch doctor medicine. And if you don't know what's going on with your patient, maybe you should be trying something else. That's my opinion about this paper.
Ladies and gentlemen, this was the best of John, one of best of John Ince's usual performance, and I am really happy to have you again here, John. We have been together on conferences, sessions several times, and somebody, you know, some people just don't age. Great comment, and well, true. I mean, from the trialist point of view, I would have been very surprised if any of my papers focusing on mortality on 10, 14 patients would be accepted like this. And
exactly.
And yes, it's difficult to come to terms with that. Anyway, so one last question to you, because you treated a lot of patients, possibly by that time hundreds of patients, and the safety is another issue, because CytoSorb not only removes the cytokines but also other substances. Any comment on that? And then I would like to get back to John on this endothelial thing and the COVID or one more, but let's just oh no, turn it around, John. Let's go back to you. You mentioned COVID-19 and the lungs and endothelium, and I think endothelium plays an extremely important role in the pathophysiological process of COVID-19. So by removing, if there is a cytokine storm, of course, because it is not a common feature for COVID-19, but from the physiologist point of view, could removal of cytokines help the recovery of the alveolo-endothelial interaction in these COVID-19 patients? What is your view on that? I haven't heard.
I would be, let me put it this way. I would be surprised if I were a doctor and had to go for treating these patients. I would definitely target the endothelial cell of the lungs. So I think nebulization of different types of compounds would be much more effective than a systemic removal of cytokines. We saw no plugged capillaries or thrombuses in the microcirculation of these severely ill COVID patients, but they resembled much more our Himalaya climbers who were recruiting their microcirculation, had much more capillaries there, dealing with hypoxemia. But interestingly enough, up to a SOFA score of 12. So these patients were able to compensate for the hypoxemia until a certain level. That was for me a key insight into the physiological response of COVID patients. So I wonder if the cytokines itself are probably leading to endothelial dysfunction, which is probably why dexamethasone works so well. Again, remember all those trials on steroids? Didn't we forget that? And now all of a sudden dexamethasone is the big, I find it incredible. But anyway, so that's what I think about COVID. We really need to understand the pathophysiology of COVID. It's a completely different disease than sepsis is.
Right. Well, thanks a lot. Willem, Pieter, if you have any comment on this, please go ahead and then respond to my final question on safety.
Yeah, well, I don't really have additional comments on what John just said. And as for the safety, we didn't see any problems with uncontrolled infections or antibiotics, but still, I have to say we didn't measure the antibiotic levels in this.
Did you measure antibiotic levels regularly in your hospital?
Well, we didn't at that time, so I didn't have any indication that that was a problem. And I think we all know that there's underdosing in a lot of patients as well for antibiotics. I'm not really sure what the effects are. There's new data from CytoSorb on the antibiotic levels, and I think that dose adjustments would be preferable. But I didn't see any problems in our study.
Yeah, if I could just say something on the antibiotic story, it's a very difficult issue for a start. Don't forget that any extracorporeal circuit will take away antibiotics, whether it be cardiopulmonary bypass, CVVH. No one ever talks about that. So that's another, I think, important issue to take into account. So I find, and also what makes a very confounding factor is that the antibiotic therapy used in different countries is very, very different. So here in the Netherlands, we use selective decontamination, which is a mix of different antibiotics, which is not used in other countries. And so it's very difficult to evaluate the literature on the effects of different types of antibiotic strategies on, well, infections and sepsis in general.
Yes, well, thank you very much. We are almost reaching the end of our time frame. Of course, it is 30 minutes, but we are very flexible in this, and I really enjoyed this discussion, and I hope that the audience and those who will watch the video on this session will enjoy it as well. So any last comments from your side? Any burning questions? Well, if not, during our discussion, I prepared kind of a summary slide, and I will try to share my screen in a way that this time the right screen will come up. So in my view, the take-home message that your data is very encouraging, that there might be a survival benefit, and I agree with Will and Pieter that for somehow we have to show it in a prospective randomized study, or test it in a prospective randomized study somehow, but possibly with much better patient selection. As before, John is shaking his head, but of course I didn't expect anything else. And of course, I give you the chance, alternative outcomes, and we have been designing now studies with alternative outcomes, and I must say that I'm very happy that from Derek Angus's group and from large centers now, papers are published in JAMA and New England Journal of Medicine with other primary outcomes than mortality, and it is basically the length of organ support, vasopressor and ventilation-free days. And I couldn't agree more. And this is a new trend, and the new designs, the adaptive designs, I think we have a very bright future ahead, and we may just really change the full concept of intensive care research. And then, although there is this lactate level in your paper, but we all agreed that we shouldn't use cutoff values. And I mean, I have been involved in biomarker research, and this was one of the things we learned, that you cannot really use cutoff values for certain biomarkers like procalcitonin or CRP or whatever. And this is completely against the trend of personalized medicine. So don't use them to making decision. Look at the full picture, and if the patient, you think that the patient has perspective, has a chance for survival, but the clinical condition is not improving, then consider adjunctive therapies. And this leads to us this refractory shock as an indication, which is a very important clinical perspective and clinical condition, which is a life-threatening one, and the longer it goes on, the less likely for the patients to survive. So finally, I would really like you, John and Willem, Pieter, for joining me during this discussion, and enjoy this very warm weather over there in the Netherlands. I hope to see you soon in person, if not sooner than on the Brussels conference. And together with all the others who we miss for a year and a half or so.
We do.
Yeah, we miss each other. What we will meet, and there is a light at the end of the tunnel. And dear audience, I would also like to thank you for participating, and for all of you who will watch this later on. And I would also like to thank this massive team behind us who have been helping, especially Teresa, Stefania, and Volker with answering your chats. And of course, the technical team, Igor is with us in the background, but all the others, and I cannot really go through all the names because this is a really huge team effort. So I wish you a very nice and pleasant evening. And ladies and gentlemen, goodbye. Grab a cup of coffee and enjoy a sip. Now without a science. Cheers. Bye-bye.
Bye.
Bye-bye. Thank you.